Good morning, and I'll be talking something on artificial intelligence or applied knowledge. And when Chetan gave this talk, I was just looking what is applied knowledge. And actually, last couple of years have seen lot of improvements in CPU, in mathematical modeling, big data, and we are hearing a lot of these terms of machine learning, deep learning, and there is a big upsurge of social media, internet of thing devices, and automotive industry, and all these have actually uh, improved our capacity of image, speech, and more motion recognition, and more last year it has been the natural language processing, and this all has made a lot of uh, entry of artificial intelligence based devices in screening and diagnosis of multiple conditions. So these are a set of devices which FDA has approved, which use deep learning or artificial intelligence for diagnosis. And we have one, you can see IDX device that was in April 2018, got the FDA approval for diabetic retinopathy diagnosis. Applied knowledge is something learning with various situations or contexts, like advice or a process or what we learn from our experience. So the question is both the thing comparable by any way? Today, what AI can do in retinal disease is it can automate a repetitive task which we can do, but probably it may not be the best use of time, or there are not many ophthalmologists. Like for screening, we need many ophthalmologists to screen diabetic retinopathy. We don't have so many, or people have tried using it to find new signals, things which we cannot say, probably a predictive model which becomes a cornerstone for prevention. I'll give one example on diabetic retinopathy screening, how AI is being used, and there have been lots of literature, lots of algorithms, and any of these algorithms who have used deep learning, the sensitivity specificity seems to be very accurate in diagnosing either a referable disease or the international classification, the 5 stages of the disease, or just mere presence of diabetic retinopathy versus absence of a disease. If you look, for some of the facts are that now we have algorithms not only for a posterior pole or a 45-degree image, even for a wide field image 200-degree, we do have algorithms which are fairly accurate. There are evidence that these algorithms work similar in various ethnicities, so it's not like what has been developed in India will not be worked outside. It works on any ethnicity. One thing we must understand, the performance of these algorithms vary across the stages. So if you look at the output, very few have spoken about starting from mild, moderate, severe, PDR, each stage what is the accuracy of the model. Majority talk about referable, which they consider as a moderate plus diabetic retinopathy. So there is difference in the stages of retinopathy. With good accuracy, majority of these algorithms can predict whether an image is gradable image or a non-gradable image. So that's something which is very good. And of late, some of these devices or some of these algorithms also give us a heat map. Heat map meaning that why it told that a disease is a moderate or why it is a severe disease. But there are a lot of applied knowledge in DR screening. So we all know that retinopathy lesions are dynamic. There are turnover of microaneurysms, exudates, hemorrhages, and how these AI will differentiate a resolving hemorrhage or a resolving exudate was a question. Again, it doesn't talk about multiple risk factors. So when we do a screening, there is an intuitive feeling. We have a patient with a longer duration of diabetes, we look more carefully, which probably these algorithms will not do. Again, not all process of screening is photographic. Majority in India still do an indirect ophthalmoscope or even a direct ophthalmoscope for a screening. And in presence of media opacity, definitely our clinical examination, we can detect the presence of disease where AI will say it's a non-gradable image. And again, there are challenges taking photographs in so many of these patients. So currently the way AI is used, what I am aware in India, is either or fully automatic mode where the cameras are in a physician clinic and screener has got no or minimal skill to grade diabetic retinopathy, or can be used as an assistive mode where people who are not that much trained, it helps them uh, give more insight into the diagnosis. So this is what we intend to use, a more of assistive mode. So we have now integrated it with our EMR, and we'll be now soon starting the pilot study with some anterior segment surgeons. So basically the workup at Shankar Nethralaya is the initial optometry workup, and once the optometry workup is done, a consent is taken, the images are collected, the images are uploaded, the retinal photographs are uploaded to the EMR. That's the first step. So you can see the images being uploaded, and we also put whether it was taken with a dilated or a non-dilated mode, and assessment whether it was cataract was present or not. Then it goes to a consultant. So he gets to see the image. He has a chance to grade again. He can grade the retinopathy levels, and he says view the automated one. So he also gets the automated grade, and he can revise his diagnosis, or if he feels that his diagnosis is correct, he can still continue. So we use it more as an assistive device rather than the automatic device. New signals, like we tried working on, can we predict neuropathy using retinal image, which actually we looked at both neuropathy and nephropathy. To our surprise, as a clinician retinal surgeon, we feel that nephropathy should definitely be picked up with retinal images, but we found that neuropathy actually picks up much better. Just seeing the retinal image with a very high accuracy, we could predict diabetic neuropathy. Another predictive model we have been working, one of the genetic signal, no, this is not the genetic, to differentiate AMD and PCV. We have trained a OCT algorithm we have made, which can very accurately diagnose whether this is PCV. So these were all PCVs which were proven by ICG. So that was the label which was given to the algorithm. It also shows the heat maps, what was the part it looked at to identify it as a PCV. We found one of the genetic factor which was actually associated with response versus non-response in a PCV for anti-VEGF, and we tried making a AI algorithm for it, which can, you put an image and it can tell whether this type of this genetic factor is present or not. That also is fairly accurate. Now the big question is, can we combine AI and applied knowledge? And that's what that would encompass, using EMR notes, probably a lab report, handwritten notes, evidence from multimodal images and the retinal imaging. Just last two slides. And the buzzword in 2020 is natural language processing. So not only the ML deep learning, but use this NLP, which gives us a chance to use all these handwritten note or unstructured data and generate an AI model from there. There have been very recently, last month, a paper which came to use NLP along with images, and they found that with mammogram and the health records, very accurately they could predict the malignant transformation of a breast tumor. And we have started our work thanks to Department of Biotechnology using NLP and all other technology, genomic and big data, and MV Diabetes is our partner, trying to look at, can we develop an AI model based on these. So the question, like whether we need to have applied knowledge or AI, the answer is probably both. And now we are having AI models which will use applied knowledge to diagnose and help us predict the disease. Thank you very much.